This tracing has got some irregularity to it. How can we describe that irregularity? Well, we've got a number of QRS complexes here that look fairly regular. There's a little bit of variation between some of these here, but we've also got this beat and this beat that stand out that are a different morphology, and they are also early, right? They come in before you would expect based on the duration between these other QRS complexes here. So it is an early beat. So is it premature atrial or premature ventricular? And we assume that it's premature ventricular because the QRS complex is wide. So these are PVCs right here. So those PVCs are going to make it difficult to accurately assess the rate based on the big box method, although it's not that far off. So if we were to count with big boxes, let's see, here's one, 300, 150, 175, so in the 70s. And then if we count and multiply, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 times 6 is 72. So it actually doesn't alter things all that much. So the rate is somewhere in the 70s. PVCs is part of the rhythm. The other part of the rhythm, what are the other ones doing here? Well, that looks like an upright P wave there in 2. Looks like we have those before just about, all the rest of the QRS complexes, so looks like it's sinus rhythm. Axis is normal, up in 1, up in F. Intervals, PR interval looks fine. The QRS for the natively conducted complexes looks fine. The QT is well below half the R to R interval here, so that looks to be fine as well. There's no real evidence of block here. A can look like it's conducting to VE just fine. Ischemic changes, you do have some T inversions. Where do we see those? Lead 1, AVL, V5, V6. So I would classify those as lateral. So lateral T inversions. And that's really all that we've got going on here. We've got a heart rate that's somewhere in the 70 to 80 range, sinus rhythm, PVCs, and some lateral T inversions.